Hello, yes, my name's Claire. I'm a speech and language therapist. I've worked in neurology and I've done some head and neck surgery as well. Speech and language therapists, you may or may not know, work with people with swallowing problems. This is because we've got a vast knowledge of head and neck anatomy. Most people think of a swallowing disorder as in dysphagia, but dysphagia isn't itself the only problem. So SLTs tend to describe swallowing problems under the banner of EDS, which is eating, drinking and swallowing disorders. And that's how I would describe it rather than dysphagia. So in the States, they refer to it as deglutition disorders. So what I'm going to take you through is a very brief summary of what is a functional swallow or deglutition, because it's not just about the swallowing function, and what are some signs of dysphagia to be aware of in some of your clients who've got neurological impairments. So what we talk about is the different stages of swallowing. So if you were to get a report from an SLT, they would describe the stages. So when we have a reflexive swallow, that's what we do when, like I just did just now, we swallow without thinking about it. We swallow in our sleep. When we maybe take an intake of breath, we might swallow afterwards. That's a reflexive swallow. And there's 3 stages to that. When we're eating and drinking, there's 4 stages. And this is what an SLT would look at. So first stage is the oral stage. So that's when you chew. And that involves obviously your tongue and your jaw and your teeth and your cheek muscles and your soft palate. So if a speech and language therapist was going to assess one of your patients, they would be looking at all the oral functioning. Now you could have a client that's actually got a EDS disorder, not because they've got a problem with their actual swallow, not because they've got a problem here, but they've got a problem with their jaw or their teeth or their tongue. And that may make a speech and language therapist make a decision to put somebody on a modified diet or no by mouth because this stage is impaired. The next stage is the pharyngeal swallow. So this is the bit that most people think about when they think about swallowing, is what happens in your throat. So it's a combination of your larynx and your pharynx. And then the esophageal phase. So the esophageal phase is obviously between the bottom of your larynx to the top of your stomach. So not a lot of people know this, but speech and language therapists also know a lot about esophageal functioning. We do tend to pass that type of disorder over onto gastroenterologists and dietitians, but we need to know about the whole function from the lips all the way down to the stomach. Anything on the alimentary tract, the alimentary tract is from the very front of your mouth to the very end of your bottle. Anything there, surprisingly, can cause a problem with swallowing. I've had patients who've been in care homes on multiple medications and they're very impacted. They've got fecal impaction. And as a result, they end up swallowing their own feces. So the feces comes back up and they regurgitate it and it goes into their lungs. So speech and language therapists have got a lot more knowledge about the whole tract than most people would think. So the point I'm making is that swallowing is a lot more than just here. It involves a lot of stages. So when we're looking at the anatomy of it, this is what we would consider. We'd consider how somebody chews, how they get that bolus back to the back of their tongue, how they move that down. So it involves what's happening here and what's happening behind it. And then is it going down to the esophagus? So sometimes I've had patients that this bit and this bit is working fine, but they've got esophageal issues. So there's a whole load of disorders that can cause dysphagia or EDS. And sometimes it's esophageal. So that's part of our assessment process. It's differential diagnosis. Is it oral stage dysphagia? Is it pharyngeal stage dysphagia? Or is it esophageal? Or is it something completely different? So I'll give you a quick video of how we actually swallow. So like I said, this is an American video, so they talk about deglutition. To be trained in dysphagia is a postgraduate training. So people will get the undergraduate aspect of it during their degree, the theory of it, but you have to do postgraduate training on top to be qualified to do dysphagia. Not every speech and language therapist is qualified to do dysphagia. Not everyone can do neurological dysphagia. Not everyone can do head and neck dysphagia. So I can do both of those. but that's because of the experience that I've had. So if you're wanting to refer your clients who you suspect has got an EDS, you need to make sure it's a speech and language therapist that is trained in neurological dysphagia, because there's so many components to it. And the problem that we have with a lot of our clients with neurological conditions is that they have a lot of concomitant disorders as well. So somebody might have a slight neurological dysphagia, but that might not be the biggest problem. It might be their positioning, or they might have a respiratory problem, or they've maybe got like an esophageal cancer as well. So sometimes you can go and see a patient who's got an EDS, and there's actually multiple causes of it. So that's why you need an SLT that knows how to basically differential diagnose and look at all the different stages as well. So a quick quiz. Kate has told me that the chat is enabled, so you'll be able to put your answers in. So there's 12 cranial nerves that are sensory and motory. How many of those are involved in safe chewing and swallowing and eating and drinking? Is it 4, 5, 6, or 8? So if you could, would you be able to put what you think the answer is in the chat? And the next goes put 1 and then your answer, A, B, C, or D, or 4, 5, 6, or 7. Okay, can you see anything coming in?
Yes, we've had a few answers. D so far, somebody said. D, again, popular. People are being very shy. 8, D, 1, C. So a bit of a range. C, C, D, C. A real mix. Mostly C and D.
Okay, right. So I think this answer depends on a couple of things. I would say the answer is C. Yeah, 6. Some people say 5, some people say 4, and some people say 8. So when I was training, we were taught that it's 8 because you use your eyes and your smell to eat. Well, that's not actually true. Like, you can eat and drink safely by being blind and not having any sense of smell. So it doesn't mean that you can, I mean, it makes your enjoyment of food better to be able to smell it and see it, but it doesn't mean you can't swallow safely. So 8 is out. I always say 6 because some of my colleagues would say 5 because they don't include the accessory muscles. Now, I always include the accessory muscles and nerves in my assessment. So this is down here. So if I've got a client who's got a floppy head because their accessory muscles are damaged or the nerves down here are damaged, that's going to affect their ability to eat and drink. So if I've got somebody who's like this, that's going to affect their ability to eat and drink. So I always would assess, does somebody have good neck function? Because you can imagine it, if we're eating and drinking, we tend to be in this position. We're not like that or like that. So for me, all the nerves that have to be working functionally are a 6. You can function a bit less on a 4 or a 5, but not less than a 4. But you're going to have problems. If you've got somebody who's very cognizant and has got good mobility and awareness, they can function on a bit less. However, that's highly unlikely because if they've got that kind of level of nerve damage, they're going to have a load of other problems. So generally, I would go for C6. So well done for those that said that. Okay, how many muscles of the head and neck are involved in a functional swallow? 5, 25, 50, or 75. And these are rounded up. You know, when you look online, it gives you approximations of this, but what would you think? You have to say there's a lot more muscles in the head and neck than you think.
I think this one is a hard one. We've had B, 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 C, 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 B, C, C. So people tend to be going for B and C, so 25 or 50.
Yeah, okay, so C. So it's about 50 muscles. So, you know, if somebody's had a brain injury and, you know, they've got 6 functioning nerves that help the main drink safely, and, you know, those nerves are affected, it's going to affect an awful lot of muscles. But also you've got the trauma on top. What about the people that have had, especially in their car accidents, that facial impact? The nerves might be intact, but the muscles might be damaged. And then you've got people that maybe got a fractured jaw, they're missing teeth. So all of these things need to be looked at. I mean, obviously, you know, we don't go around and individually count the muscles that are working or not, but there's clusters of muscles. So all of these things need to work in synchronization for somebody to be able to safe swallow, especially after a very traumatic injury. I mean, if somebody's got, like say they've maybe had a stroke and they've got very focal damage, they can have a very severe dysphagia. That means they never eat and drink ever again. But they're more likely just to have a bit more of a specific problem. But a brain injury, of course, you can have spinal cord injury on top, and then that's going to affect their ability to move their head, which is going to affect their ability to eat and drink. So 3 more. Approximately how many times a day when we're awake do you think we swallow?
D, C, C, D, D. People are saying D 2000 and C 1000. And we've had a couple of people say 100. Yeah. So I would say mostly people are saying 1,000.
That's right, yeah. So when we're asleep, we swallow about 100 times. And that's the reflexive swallow that I was talking about. In the daytime, it's about 1,000. So if somebody's got a dysphagia, or they've got any other difficulty eating and drinking because of issues we'll come on to later, that ability to swallow to clear just saliva and clear any residue that's in your mouth is greatly diminished, which increases the risk of them having an aspiration. So if it's not going to be swallowed, what tends to happen is it trickles down the back of the tongue and it'll go into an open airway. So if we can't swallow 1,000 times a day for whatever reason, your increase to getting a chest infection and choking is going to go up. All right, what's the gag reflex for?
So we've got A, sneezing, B, swallowing, C, coughing, or D, vomiting. And so far people are saying vomiting. Vomiting, vomiting, swallowing, coughing, vomiting. It's mostly D, vomiting, and B, swallowing. I'm getting through here.
I'm getting a suspicion that there might be some speech and language therapists in this call. Yes, it is for vomiting. Yes. So the reason that we gag is to vomit. Now, I mean, you can, for many years, I've had doctors tell me that, or have asked me, can I assess somebody's gag reflex? And I say, well, no, I can't. I can come and do a swallowing assessment, but I'm not going to assess the gag reflex. People can gag and swallow safely. I mean, people can not gag and swallow safely, and people can gag and not swallow safely. So having a functioning reflexive gag does not mean that somebody can eat and drink safely. And unfortunately, still in some hospitals, there's still this belief that the doctors will go and hit the focal arches, and if somebody gags, they go, oh, they can swallow fine, until they get a raging chest infection, and then the nurse usually refers to speech and language therapy. So don't make the gag reflex mean anything. It can mean that there's a cranial nerve damage there, which could indicate dysphagia, but it doesn't mean that they've got dysphagia. And what does the vocal cords do during a functional swallow?
So it's A, close, B, open, C, vibrate, or D, relax. And I have to say we've had 1 vibrate, and then the rest, people are saying A, close.
Oh, yes, so they do. So during a functional swallow, what happens is that the larynx goes up and forward and the vocal cords close. So that's another protective way to stop anything going down the wrong way. So should be the only thing that goes through there is air. And if something goes through there that's not air, hopefully we should have a functioning cough that coughs things back out. So that's another way to stop things going down the wrong way. So speech and language therapists might listen to people's voice, and our voice tells us a lot about what's going on neurologically. So if somebody's got a really sort of weak voice like this, or it's raspy like that, then I would be concerned about maybe the safety of their swallowing. Doesn't mean they do have a swallowing problem, but it could indicate that something's amiss. So the 12 nerves, so we've got the cranial nerves. So you can see you've got number 12 for the tongue and 9 for the hypoglossal. That's there. 10, the vagus nerve, my favorite nerve of all. The vagus nerve is very important, and it goes lots of different places. And this was talking about the accessory nerve as well, number 11. You see it's down in his arms. So not only is that for head positioning, but it's also for feeding. So if a client can feed themselves, they're less likely to have a problem with eating, drinking, and swallowing. Doesn't necessarily mean that's the case. If somebody's got reduced cognition, they've got poor awareness, they've got behavioural problems, feeding themselves can actually be more dangerous, and you might need an assisted feeder to help them. But I tend to find if somebody's able to lift up and do this, they're more likely to be more functioning with their swallowing as well. So we need to have good facial muscles as well. We need to be able to chew, and all of these things together, working in synchronization, not just with the muscles, but also with good cognition. So what we were always told is before you can recognize something as being dysfunctional, you need to know what it looks like as being functional. So I'm just going to show you, we'll show you two videos. I'll show you vocal cords that are working and vocal cords then that are not working. So, you know, there's different stages of dysphagia. There's in terms of can somebody function, and it isn't just the swallow that we look at. And this is really the point that I want to make in this whole talk. We look at an awful lot more than that. We look at the person's overall positioning. We look at their head positioning, their torso positioning, are they able to feed themselves, and really their cognition as well. If somebody's able to follow our instructions, we can give specific advice on how to manage a diet safely. So earlier in the video, it said the pharyngeal aspect of the swallow was not under volitional control. Not when we're just like eating as we normally would have our lunch, but speech and language therapists can work with some clients who have good cognition to actually increase functional strength in the pharynx, and then it does become functional. But I have to say, it's very effortful. With my clients with brain injury, trying to do swallowing exercises over a long period of time, multiple times through the day, does become very, very tiring, especially when they've got a whole lot of other conditions that they're having to deal with at the same time, like pain and positioning and memory loss and anxiety and all of these things. So what I have seen in some hospitals is that an SLT's done some therapy for somebody, it's worked really well, and well-meaning staff on the ward have not referred to the speech therapist for the next person because they've just copied and pasted those exercises, but it might not work for the next person. So this is what we call a video fluoroscopy, and this is quite an old video. It's very grainy. They're much better quality now. And this person does have some dysphagia, but their swallow is functional. So they've got a swallowing problem, but it's not making them choke. It's not going down into the airway, and they're actually able to get food and drink in. This is not one of my patients, so I don't know whether they're able to eat and drink enough to meet their nutritional and hydration needs. What we might do with some patients is we give them something to eat and drink, but they maybe get their nutritional and hydration needs met elsewhere. So they might have an NG tube or a peg to actually get them better, but we give them something orally. So one, it's pleasurable, and two, hopefully it just actually might strengthen the swallow a little bit if that's possible for the condition. What you see in the black, that's the barium, and there's just a little bit sitting there. You can see a little bit sitting. I'm pointing, and you can't see me pointing. You see, there's no cough. Doesn't look like there's anything go down into the airway, but there's a little bit sitting there, right on top of the crowd. But it looks like they've got some sensation and they're able to clear it, and that's a good sign. Do they have a spontaneous swallow, or do they need the SLT to say swallow, swallow, swallow? So what we're looking at is like how fast it moves from the mouth to the back of the mouth, down the pharynx. Does anything sit in the esophagus? So this is what the radiologist is doing. It's following it down to see what's the speed of the motility. Does anything get stuck? Does it come back up? And part of the SLT recommendations could be, right, you've got a solid or a semi-solid. It's got a little bit stuck. Maybe have a drink to get that to go down, because if it doesn't go down, the risk is comes back up the esophagus and tips into an open airway. So you can see there's a tiny little bit sitting there on the right hand side. It looks like the left to you, but it's on the right hand side. So what they're doing here is they're turning the person's head to the right to block off that weak side, and you see it's now gone. So that's a very typical technique used by SLTs. So there's lots of different conditions that can cause dysphagia. And, you know, I've had referrals for somebody having dysphagia, and all they've had is just a really dry tongue. They've been in hospital for weeks. They've not had anything to drink. They're on lots of medication, and their tongue is really dry, and they can't drink and they can't eat. And if you give them good oral hygiene, which is a very important part of what happens in a hospital or should, then dysphagia miraculously goes away. So your client, after a serious injury, they could have a brain injury that's caused it. They could have a spinal cord injury, high level, that's caused it. But they could have all these other things going on. They could have osteophytes up at the top of their vertebrae. They could have a concomitant progressive neurological disorder like MND or MS. Some of our clients who are older could have, well, not even older, dementia. There's a lot of people with long COVID that are finding they've got dysphagia. Old age causes dysphagia. Medication side effects causes dysphagia. So there's a lot of things, and this is why an SLT who's got experience should be able to take apart, like, what's causing this and what's causing that. So the other conditions that we would assess from a speech and language therapist point of view is, do they have weak muscles of their tongue? So do they have slurred speech? So they're dysarthric. Do they have dyspraxia? Is it uncoordinated? Do they have dystocia, which is because your cough is important to get rid of anything. So if something's gone down the wrong way, people say that it's gone down the wrong way, that means it's gone down into the larynx. We cough to get rid of it. That's nature's protective mechanism. And if somebody doesn't have a functioning cough, that's potentially very dangerous for them. As I said, dysphonia, if somebody's got very weak voice like this, it could often mean that their vocal cords are not coming together. We look at altered sense of taste, of smell. Do they have a dry mouth? Do they have too much saliva? All of these things can cause more problems with eating, drinking and swallowing. And just to note, dysphagia is a language disorder. So I've had plenty of referrals asking me to assess someone who's got dysphagia because they can't eat and drink. It's the difference between an S and a G. So the signs that we'd look for, especially if somebody can't communicate, if somebody does have a communication problem on top of dysphagia, which is very, very common, or they've got a cognitive impairment. Like, you know, I've worked in many, many care homes, and a lot of people with dementia, the dysphagia happens very slowly. So what happens is that they modify their diet over time. So they've pretty much got presbyphagia, so old age swallowing. Then they get dementia on top, which speeds it up. And they've just slowly cut out the crumbly biscuits, and they drink their tea a bit cooler and a bit slower. And they've stopped eating steak and they're now eating mince, you know, things like that. So it's not overt. But the things that we would look for is, people think swallowing problems are all about choking, but it's a lot more other things than that. You know, does somebody have a repeated chest infection? Are they always going after they've had something to eat and drink? Are they just avoiding food? Are they coughing? Are they dribbling? Just these wee things that tend to be overt after a major incident like a brain injury, but if somebody's a bit older, it's a bit more subtle. So here's some of the signs of dysphagia. So, I mean, you know, it's rather optimistic to say that go to speech and language therapy and we can do some exercises and fix your dysphagia. It isn't always the case. And a lot of conditions are management, especially if somebody's got, say, a progressive neurological condition. We can't fix somebody's swallowing problems with MND, but what we can do is we can modify the diet or modify the environment around them. And when I say modify the environment around them, that includes the staff. So I'll come on to that in a minute. So some of the risks of unmanaged eating, drinking and swallowing problems is, you know, like people say to me, it's okay, they're coughing. I know they're coughing it out, But if you think about it, if somebody coughs and coughs and coughs and coughs and coughs, 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 that's going to start to diminish the effectiveness of that cough. If you went to the gym and you were lifting a weight and you did that for an hour, eventually this muscle is going to become a bit weak and ineffective, and then you won't be able to wash your hair the next day. So same thing with a cough. If it's overused, then it becomes ineffective. You know, if somebody's choking all the time, that's horrible. I mean, if there are speech and language therapists on this call, like, you know, you're fully aware of the distress that occurs when somebody's choking. It's horrible to watch. And I've seen lots and lots of people choke. And this starts to develop a phobia. So people start to avoid food altogether, which then has got other consequences, the malnutrition and dehydration, and all the things that come with that, like skin breakdown, cognitive issues. People start to get pain on swallowing. So again, they start avoiding. Repeated chest infections. I mean, if somebody gets a chest infection over and over again, it will kill them. I've seen lots of patients whose cause of death was recorded as aspiration pneumonia. And basically, from my point of view, it was an unmanaged dysphagia. Had this dysphagia been managed properly in the acute or care home sector, they probably would have died eventually, but they would have lived longer, healthier. You know, if somebody's malnutrition and dehydrated, it leads to a whole lot of issues. If we've got a client who's going through the rehabilitation process from a personal injury perspective, we need them to be maximised in the nutrition and the hydration. If they're avoiding food, if they're not on the right food, they're not going to benefit from everything: speech and language therapy, occupational therapy, physiotherapy, psychology. So that needs to be managed so they can get better in other ways. And it's depressing, not being able to eat your favourite food, not being able to eat with the family. And there's a wider family dynamic here. I've seen it when I've had clients who've gone home and they've maybe been peg fed. And then what did the family do? Well, they're sitting down to a meal while the relatives in the living room watching television with their peg feeds. You know, it causes a lot of social dynamics as well. And that causes a lot of sadness. So, you know, unmanaged eating, drinking, and swallowing problems does cause death. So if you're looking for chest infections, when you see it here in the shaded area, so you can see on one side, there's a little bit. So the bit where you've got the underwire bra, there's little scatterings there. On the other side, it's quite consolidated. So that's what we're trying to avoid. And I've seen some clients that, you know, they've maybe got a chest infection, and especially in the acute sector, they say, well, just get the physio in to clear their chest. The physios can only do that so many times. Antibiotics only work so many times. We want to stop it so it doesn't get to the point of consolidation, because this is what ends up killing a lot of the clients. It isn't so much choking on something, it's the fact that their lungs give up, because all the lungs are just so full of scar tissue from trying to recover over multiple months, years of aspiration pneumonias. So this is what it looks like when somebody does have a swallowing problem. So you look at the difference between the vocal cords here and the little lip that you see at the bottom of the screen. That's the epiglottis. That's what should cover when we swallow. So the vocal cords close and the epiglottis covers when the larynx goes up. And all this green stuff around there shouldn't be there. So if we're coming in to see somebody, before we do any swallowing, we look at all of these things. So it's not just about the swallow here. It's not just about dysphagia. It's about the whole eating, drinking process. And all of what's included in that is somebody's ability to follow instructions. Because what we do is that we can't fix a lot of dysphagia, but what we do is put a lot of management strategies in around it for the client to hopefully comply with, and the wider staff and the environment, our family. So they need to be able to understand what we're saying, and they need to be able to take it in and remember it. They need to be able to process it. They need to be compliant behaviourally. I mean, if I'm going to see a client who's blind and deaf, already there's going to be a problem with the dysphagia management. And the staff are going to have to be more responsible for that person. If I've got a client, so when I've worked in behavioural units, if I've got clients who are shouting and screaming and swearing and fecal smearing and all these things, kind of a bit difficult to do an EDS assessment, and it's much more difficult to get them to comply. So somebody's swallow might not be that bad. Their ability to chew might not be that bad, but their overall cognitive and behavioural impairments might be so significant that as an SLT, I have to put a more stringent EDS behavioural programme in around how they eat and how the staff interact with them. So I'm looking at everything, like what's the state of their mouth? Is their tongue really cracked? Do they have teeth, or is their teeth rotten? Sometimes I've recommended that a client has their teeth taken out because it's rotten. You know, when I've worked with drug addicts and alcoholics and people who have been in jail for most of their life, they tend to have pretty poor dentition. The dentition itself can be causing the problem. So, but the dentists take the teeth out, get them new dentures, and then sometimes the problem's just resolved on its own. Can they sit up and can they maintain posture? I've seen lots of people who've been tried to be fed lying flat. So I wouldn't eat and drink completely flat because I know it would be difficult for me. You've got somebody that's got nerve impairment, muscle impairment, sensory impairment, and then you try to feed them, the chances of them choking or aspirating suddenly gets much, much higher. I've had patients been in comas, and doctors, qualified doctors, have asked me to do eating and drinking assessments on somebody in a coma. So the lack of knowledge around what makes a functional swallow is quite high in the medical community. So if you're going into a care home or somebody's been cared for in home, I would say to the solicitors on this call, part of your funding should be getting the SLT to educate the staff. Because if doctors and nurses don't understand this, care staff are not going to understand it. So it's not just going, the speech therapist going in and doing this assessment before they get to the swallowing part. They need to be training the staff on what they're doing and why. So that needs to be accounted for in your funding. I'm looking for what's their upper limb functioning. How can they sit in their wheelchair, or how can they sit in their bed? And this is when I would start referring into occupational therapy and physiotherapy. So again, solicitors on the call, this isn't just in isolation. If the SLT is doing these assessments, we're going to be wanting OTs, physios and dietitians involved in this as well. So we're the main person that comes in, assesses EDS. We'd recommend, if somebody's on a modified diet, we'd recommend cutlery and crockery that they can use if they need a X-ray swallow or a scope swallow. And then we'd want the OT to come in and see what kind of adaptive aids can they support with. I've had patients refer to me for swallowing problems, and if I've got the right OT that's used to working with brain injury, the OT can set up the chair in the right way, they can get the right equipment, they can modify the environment, and the swallowing problem miraculously goes away. So it isn't always about a problem swallowing when people have got problem eating and drinking. So to me, the occupational therapist is really the most important person that I would work with, especially in brain injury. Obviously, a dietitian, if somebody's needing NG feeds or PEG feeds, if they're needing nutritional supplements, so like the 40 sips and ensures to make sure they're getting the right amount of nutrition and hydration. And then the physios, obviously. I don't want the physios to come in and do chest hygiene. If the person is being managed appropriately, we shouldn't need a physio to come and do chest hygiene or suctioning. But they are very important for things like supported seating and maybe a neck brace. There's a whole lot of things that they do, but just your speech and language therapist to refer to the right supportive therapy team. And also pharmacists. Some clients are trying to swallow massive pills. I have problems swallowing dry, like capsules. If you've got a dysphagia and then you're trying to swallow a dry capsule, there's going to be a problem. So the pharmacist could sometimes change a medication from a pill to thick syrup. Sometimes they can't, for a whole lot of other reasons, they just can't. But they might have too much saliva. The pharmacist can get it dry up. If they've got not enough saliva, they can do artificial saliva, and then they give us the thickening powders as well to make the drinks like a milkshake. The majority of the doctors that I would involve, obviously the GP, we need to keep the GP involved, especially if we're needing prescriptions. Dentists, I've made so many referrals to dentists. If you can get someone's dental hygiene sorted. It can relieve a lot of the issues. Also, dentists are very good at managing overall oral hygiene. Ear, nose and throat and max fax, they could do a whole lot of different things. It depends on what the problem is. Radiology, that's when we do the x-rays. And then depending on the problems, gastroenterology, neurology, respiratory medicine. These tend to be the predominant doctors that I would refer to, depending on somebody's eating, drinking and swallowing problem. So here's a video of somebody with quite an unpleasant dysphagia. Again, this isn't one of my clients. What we all need to work towards is the IDSI framework. So this is the International Dysphagia Framework that all the speech and language therapists across the world should be adhering to. So the problem we had years ago was that each individual hospital and sometimes trust had its own dysphagia guidelines. I've worked in really big trusts where even the different hospitals in the same trust have had different descriptors. And what was happening was that a client might go from acute to rehab, and what was thick in one place was Orla, I'll come back to that, was there might be considered a 2 in one place, but it was referred to as a 4 in something else. So this was a project that's gone on for many, many years. And now this should be universal. Even if I was to transfer a patient to someplace else in Europe, the SLT should be following the same thing. So we would take in everything into consideration. What's their dental state? What's their oral muscles like? What's their pharynx like? Their larynx like? Their esophagus like? What's their cognition like? What's their memory like? What's their behavior like? What's their positioning like? What's the head posture like? Can they use their arms? All of these, and also the staff. So I would consider how much support a client gets in the environment they're in around my recommendations. If I know that they're going to have a good member of staff that can cut everything up for them and help them feed slowly and maybe be there to prompt them, I would be more likely to say, okay, like go on a soft diet. If I know that staff are, there's not many staff around, there's not people to help cut up the food, there's, sorry, that's a locum agency calling me asking if I want to be a speech and language therapist in dysphagia. It's the vibes we're going through the world. You know, I would put them on a minced diet. I was like, if they don't have somebody to support them. So these are all the things that SLTs will consider. Or I might even have somebody on a more modified diet until I can get the OTs and the physios in to set the environment up and give them adaptive aids and have the right chair for them as well. So when you get any referral from a report from an SLT, it should include what the drinks and fluids IDSI guidelines are. And if an SLT recommends this, it's for every meal and every drink. I'll say that actually. No, I'm going to take that back. Sometimes it does depend if it's got milky drinks and everything, but hopefully the thickened fluids have changed somewhat. But I've worked in environments where absolutely desperate for me. I've worked in environments where on Christmas Day, I've had clients that have been on very, very thick fluids and pureed diet, but on Christmas Day, the staff have given them normal drink and normal fluids because, you know, it's Christmas Day and it's not fair. Dysphagia doesn't go away on Christmas Day. So the problem with pureed diets is that they tend to look, smell and taste horrible. You'll tend to find that patients who are on modified diets, thickened fluids, do tend to lose weight and are a bit more dehydrated because it's hard. If we've got to drink, what, 2 litres of water a day to stay healthy, if you've got a swallowing problem and you've got a really thick drink, like say a milkshake, that's hard to get 2 litres in and it becomes tiring. So a lot of people who've got a swallowing problem, they tire quickly. So this turns up and people don't want to eat it. So you may find that if you do have a client that's on a pureed diet, I would always refer to a dietitian to see if we can get them supplements because they don't tend to want this. I was doing an assessment in a care home in Aberdeen, and what was on the diet sheet for that afternoon was salad. and they didn't have options for people with dysphagia. So I watched the chef put all the salad items into a blender and blend it into this sort of greeny khaki splot, and then just splot it on a plate. And then they gave it to all the patients who were on a pureed diet, and they went, oh, let me eat it. So there's been a lot of work with care homes, hospitals, speech and language therapists, dietitians, catering companies to try to make food a lot more appetizing, like you see on the left. Unfortunately, it doesn't always happen. So I would just say, if your client is on a very modified diet, they may need extra nutritional and hydrational support. So these are the kind of drinks that people might get. There's the Nutilist Complete. It's a thick liquid and it's got a lot of nutrition in it, but you do need a dietitian to assess for this, because the dietitian needs to look at all the other issues the patient's got. Is the patient type 2 diabetic? A lot of our clients are. You know, do they have problems with their kidneys? You know, if they've maybe had an alcohol dependency in the past, quite probably. So there's all these other factors that the dietitians need to know before they can prescribe Nutilist. I mean, a speech therapist can't do that. You can get the thickened drinks and you can get the powder that thickens a drink. It very much depends on the budget of the trust. And sometimes if you're in your community, it also depends on what brand the pharmacy stocks and what the GP is willing to fund as well. So if they fund something called Thick and Easy, absolutely refuse it because it's awful. But Nutilist Clear is better. And there's more things coming on the market. I was part of a research project last year. Can't say anything. There is something new brewing on the market as well. What they're trying to do is take out error, because you've got these wee scoops. So the speech and language therapist comes along and says, Jim needs a level 2 thick drink, and it's 2 scoops in this. But if you go to anybody's cupboard in their house, or you go to a care home, there's multiple different vessels. So one glass might hold 250, the next glass holds 150. And then they get a mug, they get a Sports Direct mug, which holds 600 mils. The care staff are still putting in the same number of scoops, but obviously with a different volume, it can make it thicker or thinner. And that's a big, big problem that everybody's got, which of course increases the risk of chest infections and people avoiding drinking. So these are some of the cutlery that and crockery that an OT might give us. I am always very prescriptive over the cutlery and cups and glasses that I prescribe, because what I'm taking into consideration is not just the swallowing, not just does their lips close around it, does their hand work? I mean, if we've got clients that have had multiple injuries, they might have a load of orthopedic injuries, they might have lost some digits. Can they hold it? What's their head posture like? Can they tip it? Have they got a tip? I mean, for me as an SLT, that's all part of my assessment. I prefer to do it with an OT as well, because they've got, you know, the specialist eyes on this. But solicitors, this will all be part of the costing. So these things are not expensive, but in our report and in our recommendations, very specific things are there for very specific reasons. So one thing to mind is that you could have a client that's maybe had a brain injury, say last year, and they've got a dysphagia. The dysphagia isn't going to go away. No matter what the speech therapist's done, it's all about management. However, if you're looking over the lifetime of that person, what you do need to keep in mind is that if somebody's had a brain injury, research has shown they're more likely to have another one, and they're more likely to have a stroke, and they're more likely to develop dementia. So another brain injury, a stroke, and dementia all could, don't necessarily do, but all could lead to dysphagia. So stroke can cause dysphagia, and dementia does cause dysphagia. You might have somebody that's had an accident at 30, but over their lifetime, they might develop something progressive. And then if they've got a progressive neurological problem, that'll lead to a dysphagia, which could exacerbate the dysphagia they've already got. Aging leads to dysphagia from physical and cognitive decline. Unfortunately, it's for all of us. So I would say that I don't worry about eating cake and drinking wine now because in maybe 30 years I might not be able to. So it's like anything, the rest of our body ages are swallowing ages. So just eat, drink and be merry for now. But you've got an aging dysphagia on top of an acquired neurological dysphagia, it's going to cause more of a problem. When we change with posture and our vision changes and our taste and our smell, it all starts to decline. All of these are going to increase the EDS risks. As I said, when people get older, they slowly make these changes and they're not overt until there's a raging chest infection. So again, if I don't know how you would factor this into your claim, solicitors that are listening, but this is something to bear in mind for the future with a client that's got a chronic dysphagia that's not going to go away. And the biggest bane in my life are staff. The staff need to adhere to the SLTs EDS program because that's what's going to stop the client getting ill and also maximising the nutrition and hydration. When there's a change in staff, now we know if you've got clients who are going to be going home and they're going to be looked after, there's going to be a change in staff all through their life. So solicitors, what I would say is factor into your claim reviews from speech and language therapy. They may not be able to change the dysphagia, but they may need to come back in and re-educate the staff. Now, the dysphagia might have changed. You know, it might have got better. I mean, I had a client who had been seen by SLT for years, came into our brain injury unit for respite years after they'd been discharged, and the dysphagia has actually gone away. This poor person was on an extremely thick diet and pureed fluids, and I put them on normal diet, normal fluids, they were totally fine. That's a rarity. It usually tends to go the other way. So as your client declines, yes, the dysphagia will most probably get worse, but factor in for SLTs to go back in, do a review, but also retrain the staff. And that's me. That's a whistle-stop tour of dysphagia and brain injury. So is there any questions? I know there's one from Orla.
Yeah, we've got one from Orla and then one from Laura. Shall I read them, Claire, and then you can answer?
No, I can see it. So can you explain pouching, please, in dementia and its problem? Or like, do you mean like a pharyngeal pouch? Do you mean like the pharynx gets saggy and they start to pouch? I'm gonna take it as that what you mean. So as we get old, as we all know, we get saggy. We get saggy on the outside and we get saggy on the inside. And what you tend to find is like in that video there was an older lady, her pharynx wasn't contracting. So it gets saggy. Now I've had clients who've not had any neurological problem, and I've run lots and lots of VFS clinics, and the problem is a pouch. And what happens is that the food and fluid builds up on the pouch, and if it builds up and builds up at the back of the pharynx, it can then just tip into the airway, especially if somebody's older and they've got sensory impairment. We all get this, our sensory awareness starts to deteriorate. And then they get this raging chest infection, they got a lot of coughing. In dementia, I would say, or like it would be more environmental management in terms of modifying the diet, sitting with the patient and getting them to go slowly. And as you know, with people with dementia, it's very hard for them to follow instructions. So if you're starting to say, like, a speech therapist might say, okay, put your chin down, swallow hard, swallow hard. There's a whole lot, like there's a Mendelssohn maneuver, there's Masaka maneuver. There's all these different things that we could do, but you wouldn't do them with somebody with dementia. Some of the people that I've seen with pharyngeal pouches, I've referred to ENT and they've stapled the pouch, but it depends on where the pouch is, how big the pouch is, and the kind of person's overall physical and cognitive health. Otherwise, it's just more environmental management, meaning the staff. Yeah. Let's see. Laura says, I had a client who had no injury or relevant problem, that they lost their voice for months. They had a fluoroscopy, it came back normal. She can cough, but she just got a little voice. Could it be psychological? Yes, it can. So that could be a psychogenic voice disorder. What I would tend to do then is look at what's happened in her past. When you say a client, she's had no injury. Look at what's happened in her social life and vocational life, Laura. And it tends to have been several months beforehand from my experience, and then it's been brewing. I used to run a dysphagia clinic, and I had a lot of people come to me with voice disorders and didn't actually have dysphagia. I have to say a lot of them were women and older women and lonely older women. And I was asking the same question, has anybody in your family or social group recently been diagnosed with throat cancer? They're like, oh, they have. And I said, did your voice disorder start to happen a few months after that? And they're like, it did. So I would look at how old are they? I'm not a voice specialist, but when I have had voice clients, a lot of them were, if they were younger, they tended to be stressed. They had a professional life, they had lots of kids, they were running the kids around everywhere, and they were just overwhelmed everywhere in their life. When they were older, they tended to be lonelier ladies who had, there was lots of cancer going around in their sort of like social group. So it could be psychological. I would say if she's been to ENT and she's been scoped and they can't find anything pathological, refer her to a voice therapist. Orla said, I mean, we know the patient hold a lot of food in their mouth and can't seem to swallow it. Yes, right. Okay. So Orla's asked if somebody's older, like I say, especially with dementia, and they just hold it in their mouth. Well, Orla, I used to spend a lot of time in the hospital shouting, swallow, swallow, swallow now, swallow, swallow now, swallow now, much to the titillation of the people around in the ward. So shouting, obviously, because they were deaf. What we used to do, I mean, nowadays things have probably changed, probably not allowed to do it, but we used to try to just like rub their cheeks to see if that would start to get them to chew and swallow. I used to do this. I mean, this is very much what I was taught, and very much get up in there. It's not the best thing, but it will make people swallow. I would say check if you're allowed to do that anymore, but I used to do a lot of this and do that. But if somebody was quite advanced in dementia, that didn't make any difference whatsoever. So I think it would be, we try, I think it's just trying different things. Sometimes if you give people a little bit, they'll manage it, and sometimes they needed a lot. I think more with my brain injury patients, sometimes they actually needed more of a tactile sensation to be able to be aware that there was something there. I think it's just trial and error. Lemon juice, I used to use a lot of lemon juice to see if that sharpness would trigger the sensation at the pharyngeal wall, see if that would stimulate a swallow. Yeah, I think it's just trying different things, really. I don't think there's one straight answer for it. What would be the cause of dysphagia in spinal cord injury? C6. C6 is a bit low. Victoria, I would say it depends whether do they have a tracheostomy or did they have a tracheostomy? I'm used to having people with dysphagia when they've got an injury like way up here, especially if they're in this sort of position. If somebody's been in a traumatic incident, they have to be intubated very quickly. And I've found a lot of people have maybe had damaged vocal cords, or just larynx has been damaged in that emergency situation where the A&E or the paramedics just had to do what they had to do to save their life, and then there could be a problem. I would then refer them to ENT to be scoped, because C6 is quite low to have a swallowing problem. But yeah, look and see if they were tracheed or intubated. Yeah.
I think that was the last question, Claire, so I'll let you wrap up.
Okay, thank you very much. If you want to know anything else, you can contact NRC if you've got any other questions. Might not be able to answer them all, but I might be able to direct you to somebody that could. And thanks very much for listening.